Welcome to our pain management Zoom session. My name is Heather and I'm one of the trustees at FDSSUK and I'm also a patient. So just before we start the session, we want to make you aware that we will be recording the main session only, not the question and answer session. You will also notice that all the cameras and mics are off, so the only people you will see will be the presenters. Please feel free to put any questions you have in the chat box. Only the presenters will be able to see the questions, but we will try to answer as many as we can. The question and answer session will be held after the presentation. So we're going to start off tonight with a quick update on our work here at FDSS UK, and then we'll hand over to Dr. Javaid, who will give a talk on pain management, followed by a question and answer session. So here's an update on our work. So FDSS UK are part of the UK Adult Rare Bone Alliance. We work alongside other rare bone disease patient groups such as Brittle Bone Society, XLH UK, FOP Friends, Soft Bones and Metabolic Support UK. Also part of the alliance are researchers and medics. So the UK Adult Rare Bone Alliance is a rare disease collaborative network which aims to improve the lives of adults living with rare diseases. So what is a rare disease collaborative network then? The Rare Disease Collaborative Network, RDCNs, are an important part of the NHS architecture initiated by NHS England and NHS Improvement to improve the care and support for patients with rare diseases. The purpose of the RDCN is to provide better diagnosis, treatments, coordinated care delivery, research and a wider awareness of adults living with rare diseases. They do this by bringing together clinicians, researchers, patient groups and other relevant stakeholders to improve the care and outcomes for adults with rare diseases. Also to enhance diagnostic pathways, treatment options and support services for individuals affected by rare diseases. So it's important that all patients in the UK receive the correct diagnosis and treatment, and also to improve doctor, nursing and other healthcare professional training and knowledge of rare diseases. By working together, we can make a difference. Now, wouldn't it be better if all of our local hospitals had better knowledge of rare diseases and not all patients have access to a specialist centre? As part of our role as a patient group within the Alliance, we need to hear your personal experiences with regard to diagnosis, assessments, monitoring and management. Over the next few weeks, we'll be asking 4 questions via our Facebook page. It will be 1 question on each of those topics. All of your answers will be presented to the medics. It's important that our voices as parents and carers, patients, parents and carers are heard. For further information about the network, there is a poster on our Facebook page and it will be available shortly on our website. So now I'm going to hand you over to Nikki, who has some information on the next FDMAS Global Awareness Week.
Hi, I'm Nikki. I'm also a trustee for the FDSS UK. I just wanted to remind everyone that Global Awareness Week is held between the 20th and 27th of February. It is an international campaign to raise awareness for fibrous dysplasia and McCune-Albright. And there will be more information on social medias.
Great, thank you. Now ready to hand over to you, Dr. Javaid.
Thank you so much, and it's very kind of you to accept this all up. So my name is Kasim Javed. I'm a rheumatologist in Oxford, and I'm just going to give you, share with you where we are with bone pain in adults with fibrous dysplasia and McCune-Albright syndrome. Here are my disclosures. What I was going to do is share with you where we are with FDMAS. What is pain? Seems like an obvious question, but actually it's pretty complicated. What we can do at the moment in terms of assessment and management, and where we're going in terms of future horizons. And if you've got any questions, please do put them into the chat, and then we can we'll answer them as we finish the presentation. Okay, I'm just going to change my screen so I can see. There we go. I can see you now. Great. So fibrous dysplasia McCune-Albright syndrome is a rare bone disease, and basically, while the individual is in the womb, but there's a genetic change in some of the cells, and then those affected cells then affect the tissues they grow up into in later life. And you can see here a picture of a skull and a skull, and you can see there is a large fibrous dysplasia lesion in the front of the skull. It can affect the pelvis. Some individuals also have the birthmark, the classic coast of Maine birthmark, but it can also affect the hormones produced in the brain, in the thyroid, in the ovaries, and the testes, and now we seem to be finding more and more other organs that are affected. And we've sort of divided fibrous dysplasia depending on how it affects the skeleton. So with one bone, lots of bones that affects the hormones, maybe it just affects the skull, and maybe you get the muscle lumps. But rather excitingly, the international consortium is redefining fibrous dysplasia McCune-Albright syndrome. And we look forward to that, that innovation and that reclassification that should be happening next year to really simplify it, because this is quite complicated and some people don't quite understand, including doctors, what type of FD you have. But pain is also quite complicated. Pain is defined as an unpleasant experience associated with or resembling actual or potential damage. This is someone sitting on fire, burning their toes. They feel that pain from the heat, and that goes into the brain, and then they feel it, and they might move their foot away. But pain in bone is very complicated because bone also is a complicated tissue, and it has many functions. It doesn't only support our skeleton, but it has roles in nutrition, in hormones, and also providing essential components for other parts of our body. And we actually don't know very well why bone hurts. So we have some ideas. Is it due to little breaks in the bone called microfractures? Is it due to inflammation in the bone? Are the nerves abnormal? Is it because of damage to nearby tissue? There's lots of reasons why the bone can hurt. And our understanding is getting better and better and better. So first of all, we know pain is more than just pain. Pain is an experience, and it's really shaped by lots of things. And there's a really nice table here that shows that you have pain, what we call nociception, and it can be affected by social cultural factors. What are the social expectations? What's your past pain experience? Social support systems, and then it can have biological or psychological determinants that lead to pain and suffering, and then that all comes together in the individual. And we classify pain as chronic pain if it's been going on for more than 3 months, and typically has a high impact by limiting work or life activities. And as we've looked more and more into pain, the 21st century appreciation of pain has actually divided it into 3 groups. They've got quite clunky names, but hopefully you'll have a better understanding, and that might help you understand why you're in pain and why your medical team are treating you in one way or another. So the first type of pain is what we call nociceptive pain, and that's just the classical pain, where you have a stimulation of a pain fiber, either from heat or from, can be extreme cold can be painful, pressure can be painful, or any other stimulus. And basically the stimulus stimulates the normal nervous system, goes to the brain, and you feel pain. And this pain is really clearly managed by simple painkillers or maybe opioid painkillers. And we call that nociceptive pain. The next pain is different, because here the pain isn't due to a stimulation of normal nervous system. Here the nervous system is abnormal. And it's these damaged nerves or abnormal nerves that then lead to pain. So it could be an injury in the spinal cord, it could be an injury in the brain, it could be an injury further down the body. And this is a very nice study. We've looked at pain in other diseases, and we know if the bone is abnormal, you grow abnormal or damaged nerves. And maybe this is what's happening in fibrous dysplasia. The actual nerves themselves are damaged. And this pain is slightly different, where we avoid opioid or codeine-like treatments, and we use drugs more related to nerve function. So these are drugs that are used for improving nerves, maybe antidepressants or for other nerve disorders. And we hijack them to use them for neuropathic pain. And they work relatively well, and we have other treatments. But clearly here, opioids are right at the end. And we know in general, this pain doesn't respond well to just giving higher doses of morphine, for example. The final type of pain has only been around for a few years, and it's quite a new classification. We've sort of known about it for a long time, but we haven't really included it in how we describe pain. So we have nociceptive pain, where you're just stimulating a normal nervous system, neuropathic pain where the nervous system's abnormal, and nociplastic pain is really where there is a problem with how you process pain. It's real, it's definitely felt, but it's not due to damage to the nervous system that you can see physically. It's not due to exaggerated stimulation of pain receptors. It's due to how that pain is processed by the person. And there's an amplification of the pain perception. And this pain is quite complicated because it pulls in other symptoms like fatigue, problem sleeping or thinking. Some individuals are hypersensitive to sound and light, and there's often, but not always, associated mental health issues with anxiety or depression. And here the treatment is very non-drug based. We have tried drugs for this type of pain, and they generally don't work very well. And the treatment is two basic components. It's stepwise, so it gets more intense the longer you go on it. And it's what we call multimodal. So there's no one silver bullet. You need lots of different treatments, and you can see them listed here. And as we find out more about this type of pain, there are other sort of approaches. So patient education is super important. And this is about setting realistic expectations. It's very difficult to say, we've got a silver bullet and this pain will finish tomorrow. It's all about setting goals. There's a huge element of lifestyle, and sleep is probably underestimated. Getting proper sleep hygiene is actually going to be really important going forward. And that links in with psychological therapies. In those patients where there is other issues, such as depression or anxiety, they need to be managed. And there may be an avenue for physical therapy, acupuncture, or other treatments, such as yoga and Tai Chi. But in general, these sort of drugs that we use aren't very successful, and we try and avoid them in nociplastic pain. So how do we apply that sort of triad of pain to fibrous dysplasia? Well, actually, we're just on our journey. We haven't figured it out. So what do we know? Well, the first thing we know is that when you look at FD and pain, there's no relationship between how many bones that are affected and how much pain you have. So this tells us it's not the quantity of FD that's important. There's a quality aspect. There's something about the FD lesion that's actually driving the pain rather than how much FD you have. And this has really challenged us because as clinicians, we're not very good at measuring pain. How do you capture all of those different aspects of pain? We can use a very simple score saying, how bad is your pain, 0 to 10? But is that how bad your pain is now? What's the average over the last month? What's the strongest it's been? We need to be careful here. We need to think about the timing of pain, how long it lasts for if it's flaring, and also the predictability of pain. Unpredictable, severe pain is really disturbing and can very much impact patients' lives, way more than predictable pain. The response to painkillers is very important. And actually, when you ask people, all they really want to be is pain-free as possible. Another aspect of FD, which I'll come on to, is where is the pain? Because of how FD works, it can be due to pain from the bone, the joint, the muscle, or pain from previous operations in the skull. And one tool that we've been using a lot, and you can download this form from the internet for free, is the Pain Detect questionnaire. which allows you to assess how your pain is now, the pattern of pain, and where on your body it is. And then there are some peculiar questions. So does your pain feel like stinging nettles, crawling ants? Does clothing make it painful? Do you get electric shocks? Does temperature make it painful? And is there numbness or triggering? And by answering this, you can get a score, and the score very simply divides you into pain that's mainly due to stimulation of the pain receptors and pain due to nerve damage or the nociplastic amplification of pain. And this is a really crude, very simplistic way of giving you a guide. It's not diagnostic, but it helps push individuals into these three groups. And we've done some work on this. So we worked with the team at NIH, with Alison Boyce and Michael Collins, and the team here in the UK with the Rudy study, which some of you may know about. And we looked at the different types of pain. And the most striking thing is that if you look at the dotted line, which is how many people are having pain of grade 2, 4, 6, 8, and 10, that's the strongest in the last 4 weeks. There are lots of people having quite bad flares of pain on a monthly basis. And this highlights what we know from the clinic, that pain is a big problem for the adult population. And what we didn't understand and what we didn't know, and this was new knowledge, is that if you look at the type of pain and focus on neuropathic pain, where the pain is due to problems with the nervous system, very high rate of neuropathic pain. Nearly a third of all the patients were scoring neuropathic pain. This is way higher than we see in other conditions. Maybe in other painful conditions, you might see 5% or 10%, but to see a third shows that for some reason, FD seems to be triggering neuropathic pain. And having neuropathic pain made a big difference. There were 6 times more likely to be reporting severe to moderate anxiety, almost 7 times more for depression, and 5 times more for sleep problems. So it did seem to show that having this type of pain was spilling over into causing other impacts on patients' lives. But FD is complicated. That's why it's a rare disease and why we have these expert centres, and as Heather mentioned, with the rare disease collaborative networks. Because there are other reasons to have pain. So a really important one not to miss is scar pain. So it might not be due to the FD, but due to what operations you've had. And here it can be simply a case of touching the scar and see if you can reproduce the pain. And here there's some really nice work that, you can really massage the scar with oil, and you can sometimes use lignocaine patches, which I don't find very helpful, but some people do, and that can really help reduce the pain. The pain can be due to joints. So we know that as people get older, and especially with FD in the joint, that can make them wear away more quickly, which is why we're really keen that people stay as active and as fit as possible. So actually having osteoarthritis can cause pain that can be mixed with FD. And it can be even more confusing. You might be feeling pain in your knee, but that's actually coming from your hip or your back. So we have to be careful when we assess people's pain, that we know that it's actually coming from where they're complaining about pain is being felt, but it's actually coming from somewhere nearby. And then there's a whole box of people who have pain in their head or headaches. And here, this is something, and I'll show you some recent research, it's really poorly understood. We do find people with craniofacial fibrous dysplasia have a particular severe type of headache that can come on. It can be a chronic ache with quite bad flares. And we find that actually doesn't respond well to our treatments. Now, when we have pain, often it's long-standing, but there are circumstances where we actually need to know about the pain quite quickly. And this is where you get sudden, severe pain. And the commonest reason for this is an incomplete fracture or a break in the bone. And this requires a dedicated X-ray or a CT scan, not usually MRI scanning. And then if there is a micro crack, then or a crack we can see on the scans, that needs specialist referral. Very rarely you can get a bleed or an expansion of a bone cyst, and extremely rarely you can get change where the fibrous dysplasia lesion actually turns into a rare form of cancer. But that's very rare, and that will be picked up either by the X-ray or the CT. So how do we take all of that knowledge and bring it to you and bring it to your medical teams? Well, a few years ago now, 5 years now, we've published the best practice management, and this has been downloaded tens of thousands of times. And if you don't know about it, please do look it up. It's open access, which means you can download it, and there's a really helpful treatment and assessment page that you can download as an individual living with FDMAS, which will help as something like a checklist of what to do. And part of this is we have to check for abnormal nerve pain, and we ask about sleep, and we're careful about other causes of pain, but it does lay out how we treat pain. And bisphosphonates have been used a lot in people with fibrous dysplasia, and we've learned a lot about how they work. We know they don't change the size of the lesion, and they should only be used to control pain. And we know the evidence for them working is actually very weak. So whenever we ask people with fibrous dysplasia to use bisphosphonates, these are these drugs that you can get infused like pamidronate or zoledronate, it is always a mini experiment because we haven't had a successful study that shows that it really reduces the pain in FD. But from our experience, it does work really well for patients. And you may either be on zoledronate, which is longer acting, or pamidronate, which is shorter acting. We don't know why. Some people respond to pamidronate, some people respond to zoledronate. But a very important step forward is that we've created stopping rules. So you don't stay on these drugs if they don't work. And we've defined when you stop for both zoledronate and pamidronate. And it's important to realize if it doesn't work after a few cycles of treatment, it probably won't work by continuing. I need to go back and get reassessed. So where are we with what we do know about pain in FD? We have learned some things. So we know that it worsens with adulthood. So it gets worse. It's more common to have more flares as you get older. And we don't understand that because if anything, it should get better as you get older because the cells that are abnormal become less frequent with aging. It can be severe, but we don't understand why it happens. And we don't really have a way of taking someone who's got pain and saying, well, your pain is 2+ direct nociceptive stimulation of pain stem fibers. It's only 1+ neuropathic, but it's 4+ nociplastic. And if we had a way of doing that, that would be amazing, because then we could say to you, right, you need this much of this type of treatment, this much of that type of treatment, and this much of another type of treatment. At the moment, we're very simplistic to saying what's the major cause of your pain, rather than being able to say, well, actually, you need a little bit of all 3 types of treatment. And we do struggle. So these are some X-rays of people living with FD, and which hurts more. It's really, from the X-ray, you can't tell. And so what we've done is, as a community, is really worked hard to find out. And there's some really exciting work. I'm going to go now into where we are on the forefront. So this is some really exciting work where they've looked at the brain scans of people with fibrous dysplasia. And they've looked at 3 people with monostotic disease, 11 with polyostotic, and 6 living with McCune-Albright. And they've been able to pick up differences in how the brain is wired. And this is really important because this actually tells us that the intervention to improve the pain may have been triggered by the fibrous dysplasia, but is being maintained by the brain. And therefore, the way to get the pain under control is to use much more brain approaches, cognitive approaches, rather than trying to trigger and attack the fibrous dysplasia in the bone. And there's some really new work. They've actually looked at people who have fibrous dysplasia in the face and skull, and they got them to draw where all the headaches were, and they have replicated what we showed a few years back, that actually you can divide the patients into those with neuropathic pain, where the nerve fibers are abnormal, nociceptive, where it's direct stimulation of pain, and this unclear group in the middle. And the reason it's so exciting is because our understanding of bone is accelerating in step with our understanding of why things hurt, of our understanding of the biology of pain. So we used to think bone was a pretty simple structure, it's bone, it breaks, it heals, it carries you around when you walk. But actually, we're now way more aware that bone is a very complicated organ. And we're learning that from both rare bone diseases, we're learning about that from our research in cancer, and we know that we can stimulate pain from direct activation. We know about these nerve fibers can be sensitized. We're learning about how abnormal nerve fibers can grow and the role of this central processing or amplification of pain. And this is really exciting because we can use some of the understanding from these other diseases and use that to see if they could be tested in fibrous dysplasia. And there are a whole bunch of treatments that are on the horizon. So there are some drugs that we already have. So we have a drug called ketamine, which is a very strong drug, and that has been shown to have very effects on pain, actually changing how pain is over the longer term. Cannabinoids. So there are cannabinoid receptors in bone, and these are like cannabis. And we need to understand, because some of them are good and some of them are not so good, and we need to improve our understanding of how cannabinoid receptors work in bone, because it may be taking them away or stimulating other ones may improve your pain. And you can see there's a whole list of other drugs that are being developed for pain, and also non-pharmacological. So there are pain reprocessing treatments. There's an amazing virtual reality pain program where you put on the headset and you enter a virtual reality space that helps retrain that brain to stop the amplification. We can now stimulate the brain with magnets to try and do that as well as developing with AI your pain buddy. And this is an AI pain coach. But it all comes back to what sort of pain we're trying to treat. And there is some development here. At the moment, it's quite clunky how we can really define what pain it is, and usually involves putting a hot probe on and telling us when you think that temperature sensation goes from just being hot to painful. We've shown you some results from doing some very high quality scans of the head. That's still in the research area. And there's a whole area of genetics. Maybe it's you have fibrous dysplasia, but it's your pain genetics that you've inherited from your family that actually drives the type of pain you have. And that's a fascinating area of research, because that sort of brings in lots of other options for you individuals living with pain as they go forward. But going forward, there's been some really good work from Leiden showing it does make a difference. So this is looking at people who go to expert centers and looking at their effect on pain. And it's few patients and lots of caveats and lots of interpretation issues, but it did seem to think that if you go to an expert center with pain, you tend to have lower pain on follow-up, which does tend to suggest coming to an expert center where you can get managed does improve your outcomes. And we're working a lot better now on how we can do this. So we're very, very fortunate to have Melanie, who's a senior rheumatologist from Lyon in France, who's staying with us for a whole year. And she is really interested in looking at how pain works. And we do have the Rudy platform, and she is going to work with the team at Rudy to see if we can dig deeper, especially in craniofacial pain and why it hurts. And she's joining us as part of this presentation. And what she really wants to do is set up a working group of people who are living with craniofacial fibrous dysplasia and use that to create a questionnaire or a form we can use to really understand what sort of pain do they have and what's the impact of their pain. So if you're interested in finding out more about Melanie's working group, looking at fibrous dysplasia and pain, especially with craniofacial, I put the email there. And the email is also at the bottom of this page. I hope in a few minutes I'll be able to just walk you through what fibrous dysplasia is. I've given you where we are as scientists and clinicians, that we are finding pain is not straightforward. There's lots of aspects to pain, and we're really interested in about the context of the pain, both in terms of the social context, but also the effect of past experiences of pain. We do have the best practice guideline. Dr. Natasha Appelman, who's an amazing researcher in Leiden, is updating this, and we've got some exciting updates together with Alison Boyce, his team from NIH in America. And there's a huge option for research, and it really is one of the great pleasures of working in rare bone diseases, that the research and the clinical work go hand in hand, because we don't have all the answers. So every patient interaction, every clinic becomes a mini research factory, but we're trying to understand better how rare diseases work.